Okay, thank you for coming to the virtual center. I'm Carolyn Merrick, a program coordinator here. And if you came last time, Dr. Heather was having some technical difficulties. I'm grateful that you returned back. And Dr. Heather said her internet is working really well today. um, so this presentation is about keeping aging feet healthy and active. And I'll turn it over to Dr. Heather. Thank you.
Thank you, Carolyn. Thank you for everyone for coming back and joining. I see a lot of familiar faces that were here a few weeks ago when we tried miserably to do this, and I'm thankful to the Comcast gods that all seems to be working today a little bit more effectively. So hopefully we can plug through. Like Carolyn said, I'm going to kind of go through, give a spiel a little bit about how to keep your feet healthy and pain-free so that you can stay active and more healthy. To some of the familiar names and faces in the participant audience today, some of this should sound very familiar because any of my existing patients should have an earful of this every time they come into my office. And so this should be old information to all of you. But let's see if I can't share some tips for the rest of us here. Just some background information on my training. I was born and raised in New England. My family is all still up in Massachusetts. I always joke that I'm the only one who's gotten out. And I've been in Virginia now 21 years. I earned my bachelor's degree in biology from a small Catholic college outside of Boston called Stonehill, and earned my doctorate in podiatric medicine from what is now Temple University School of Podiatric Medicine in Center City, Philadelphia. Where I met my husband, got married. We both did our residencies in primary podiatric medicine at the University of Pennsylvania in Philadelphia, where I was board certified in podiatric medicine before embarking on our journey down south here to Virginia, where we have happily lived for 21 years. People sometimes ask, what is a podiatrist? A lot of times patients ask me, how did you get involved with feet? Why feet? Why do you like feet? And I always say, I had a wonderful advisor back in my days at Stonehill College, and I knew I was pre-medicine and I knew I wanted to go into medicine. And I was getting a little nervous about going into the full medical MD internist route. And my advisor looked at me and said, well, have you considered podiatry? And here I was, a 20-year-old something, and said, podia what? I had no idea what a podiatrist was. Never heard of a podiatrist. You're 20, your feet don't hurt when you're 20. At least they shouldn't. So luckily, he got me hooked up with a local alum nearby to college, and I just fell in love with the profession. I think it's a wonderful career. We get to specialize, the feet have just about all the body parts: skin, nails, bones, nerves. I get to do sports medicine, fractures. I personally don't do hospital-based surgery, but I do ingrown toenails and wart removals and biopsies and all of that. I treat everything from infants to, I think my oldest patient at this point might be 106. And everything in between. Let's see. So the foot, part of what keeps me on my toes is the foot's pretty complicated. So in each foot, you have 26 bones, over 30 joints, and hundreds of muscles, tendons, and ligaments. That's a quarter of all your structures in your body are in your feet, just below your ankle. So as you can imagine, a lot of things can go wrong. And there's probably not a month. I've been in private practice now 21 years. And there's probably not a month that goes by that I don't see something that makes me go, haven't seen that one before. There are just many, many, many ailments in the feet. So what if my feet hurt? There's a general sort of feeling out there, and I hear this from time to time, especially with some of my senior patients, is I'm old, everything hurts. Isn't it normal as you get older? Aren't your feet supposed to hurt? And the answer really is no. If things are working properly, even my advanced aged patients in their 90s and 100 can be pain free with their feet. So I want to give you some ideas of how to achieve that if you don't already. One of the things we know about foot pain in particular is that it can lead to reduced mobility. There's an old saying that says, when your feet hurt, everything hurts. A lot of my patients, if their feet are hurting, they don't want to get up and get out and go out, or God forbid, exercise. It's a struggle to even just walk across the floor to get to the kitchen if your feet hurt, or to get up and go to the bathroom. I remember one time I was actually 9 months pregnant, and I actually fell down the stairs and broke my toe. Luckily, that was the only thing that happened, was I broke my toe. But my toe hurt so badly that I remember lying in bed one night, and of course I was 9 months pregnant, so I had to go to the bathroom. And I remember negotiating on whether or not it was bad enough that I had to get up, because my toe was throbbing so much that I didn't want to get out of bed to go to the bathroom. So I know when patients have foot pain, it definitely limits their mobility, which, as you know, affects your whole health, not just physical health, but mental health too. We see when patients are less active, they start to withdraw, they're less willing to participate with different organizations and social functions and volunteering, and even, ushering at church and things like that become a struggle if you're in pain. And that affects our mental quality of life. We also know that foot pain, if you're limping or walking funny, it can lead to other issues like knee, hip, back issues. And if you're less active and you have an underlying disease like heart disease or diabetes, Lord knows that you should be out exercising and doing all those things that your cardiologist and endocrinologist is constantly harping on you. And it makes it really hard to do so if your feet are hurting. And there's some pretty significant studies that have come out in the last decade that link foot pain specifically with an increased risk of falls. Because again, if you're not walking properly, of course, you're more likely to trip or fall. And we all know that those falls can sometimes, very often, lead to hospitalization and institutional care, which typically does not end well for my aging seniors. So let's see. So some common foot problems. I just want to go through some of the most common things that I see every day. This is actually one of my patients' foot. I pretty much, run the gamut: bunions, hammer toes, corns, calluses, fungal toenails, and what I call the itises, which include the plantar fasciitis, arthritis, bursitis, tendonitis. And judging at, obviously I know this patient's foot, but judging by just looking at that picture, I can attest that she has probably all of those conditions. So let's go through a few of these. So bunion. So this is a pretty dramatic bunion. What is it? A lot of patients get confused over, is it a bunion or a callus? A bunion is actually a bump or a change in position of the bone underneath the skin. A callus is something that sits on top of the skin. So sometimes patients get a little confused about that, but the bunion itself is an actual deviation of the bone. And it's the long bones in the foot, called the metatarsal bones, that are shifting out of position. The problem with the bunion is a couple of things. One is, obviously, clearly, if you have this bony thing sticking out the side of your foot, that's going to affect how a shoe fits. And so that can cause problems being able to find a shoe that fits well. And not to mention that now you have a joint where the cartilage isn't lined up very well. So when you're walking on this joint, you're wearing away unevenly, which leads to arthritis and pain and inflammation. So here's an X-ray picture and an underlying graphic of what's happening inside the foot. And I love these pictures, and I show these pictures in my office to all my bunion patients quite regularly, because it very clearly shows that it's the entire long bone. This area here are the bones that make up the arch of the foot. So you can see how that long bone, much like the hands of a clock, drifts out of position. And then, of course, we wear a shoe, and that pushes the big toe over toward that second toe. But it's really, the problem is this bone from the arch drifting out of position. And I show this picture to patients with bunions all the time, because you can see very simply that putting something in between the big toe and the second toe, like a spacer or some type of foam splint or a pad, is not going to do a single solitary thing to push this long bone back into alignment. As a matter of fact, I tell all my patients with bunions, there is no device on the market, despite what the marketing engineers at Amazon tell you and all the catalogs, nothing is going to push this bone back into alignment. Those spacers and things, and we'll talk a little bit about that later, are effective, but they will not realign that joint. The only way to get that bone back into position is surgery. And surgery is not an option for many patients, nor is it necessary in a lot of cases. And we're going to talk about ways we can avoid surgery too. So treatment options for a bunion. I take into consideration how active my patients are, what hobbies. Are they golfers? Are they hikers? Do they play tennis or pickleball? Are they just walking around the house all day? Are they gardeners and working on a sloped surface and those kinds of things? I take all that into consideration when I make treatment recommendations for bunions. My recommendations, and we're going to talk a little bit more about shoes specifically later, is obviously we don't want anything that's going to put pressure on that bone that's sticking out the side of the foot. And we don't want to force that toe over any further. So we need to have something with a nice wide toe box. And then we talk about maybe perhaps, especially if I have a younger, more active patient, how do we stabilize the arch to prevent that bone from drifting further and further and further out? And that's where orthotics come in. Surgical options, certainly I don't perform bone surgery, so it's definitely not my first go-to, and it's not something I recommend. But there are cases where everything else fails, and I have a very active patient who just wants to get on with their life, and surgery has a place. I just don't think it should be the first line of therapy. Hammer toes, that's sort of this buckling where the knuckle of the toe sort of sticks up in a funny position. This, much like bunions, patients always ask me this all the time, do you inherit them? Yes and no. I've never seen an infant come out of the womb with bunions and hammer toes, so they're not that kind of inherited, but you inherit the foot type and the joint and muscle structure that allows those deformities to occur. And then the shoes and activities that we choose to do throughout our lifetime can determine how quickly those deformities occur, how severe they become, and how painful they are. So with hammer toes demographically, it affects everyone, men and women, same with bunions. The causes of the hammer toe, again, you inherited the foot type that allows for these tendons to become unstable and pull or draw that toe back. I will see a worsening or exacerbation of patients with hammer toes that have imbalance issues, whether it's a stroke or underlying neurological condition. We do tend to see worsening of hammer toes. It can be quite dramatic, meaning within a month, you can go from somebody who has relatively flat toes to somebody who has all 5 toes kind of sticking up like that. And again, that tends to be a neurological kind of condition. Symptoms, much like the bunion, as you can imagine, if you have a toe that's sticking up higher than your other toes, clearly that's going to affect shoe fit. and can result in skin irritation, corn calluses, blisters, and pain and inflammation. So treatment of hammer toes, here are some of my favorite treatments for hammer toes. Again, I tend to focus more on the non-surgical. Unlike bunion surgery, which tends to have a more predictable outcome, I find with hammer toe surgeries, toes tend to drift into different planes or positions. So when you have surgery to correct one position of a toe over the next several months to years, I see that toe tend to drift into other positions. So while I'm not a fan of many foot surgeries, I can tell you hammer toe surgeries on the bottom of my list. I almost see no indication for hammer toe surgery ever in any patient. We can achieve the goals that the patients are looking for, that is avoiding corns, calluses, and minimizing pain and discomfort and improving shoe fit a lot of different ways without surgery. And that can include different types of pads, devices, splints, primarily to take the pressure off the ends of the toes. I think that's important. This one here is a fairly new one that's come on the market. It's called the Hammer Toe Crutch. It's probably been out about, I'd say within the last 5 years or so. It's one of my favorites. My patients really find it comfortable, and it very effectively gently lifts that pressure off the end of the toe, especially my patients who get that really painful corn at the end of the toe. I had a patient this morning ask me this question. I probably get asked it several times a day, is what's the difference between a corn and a callus? And the answer is technically nothing. If you looked at them under a microscope, they would be identical. We just call them corns when they're on the toes, and we call them calluses when they're on the bottoms of the feet. That's all, but they are exactly the same thing. It's thickening or keratization of the skin in response to excessive pressure or irritation. So shifting gears a little bit, we'll get back into shoes a little later. Just fungal toenails, just a couple, because again, it's something I see so commonly. Fungal toenails clearly, obviously, is in a fungal infection of the toenail. That's a little broad. There can be anything from molds to fungus to yeast that can infect a toenail. There are actually organisms in all of those classes that are, by today's medical standards, considered untreatable. Just like there are bacteria that is resistant to antibiotics, there are species of fungus and yeast and molds that are also resistant to all known medical treatments for toenail fungus. Having said all that, even in fungal infections that are confirmed with a microscope that you do in fact have a fungal infection, all treatments, whether it's surgical, laser, topical, or oral medications, the cure rate for toenail fungus is dismal. The best we have seen in any study is a 14% cure rate for toenail fungus. And that's in all age groups, all activity levels, all levels of involvement, whether it's a little toe, a big toe, all 10 toes, half a toenail, or a corner of the toenail. The cure rates for toenail fungus is abysmal. And I have patients come to me all the time that have invested thousands of dollars in toenail fungus to find out that their nails look exactly the same as they did when they started. It's sad, but again, what I try to do in my practice, because we know that cures are pretty few and far between, I instead focus more on the palliative care, because a fungal infection of a nail is not going to cause a health problem unless the nail gets so thickened it becomes ingrown, like what we see here, or breaks the skin. You can have nails that stick up so far they get caught on a sock or a bed sheet and they get torn. That can cause bacterial infections and pain. So my treatment options for toenail fungus tends to be more palliative in nature, just to prevent those painful other conditions from occurring. The other thing that I inform my patients about is that, much like our hair, as we age, the keratin in our hair breaks down, which changes its color and structure and texture. The same is true of our toenails. Our toenails are made of keratin as well. So the normal aging of a toenail is it becomes thicker, more yellowed in color, and opaque. So you don't see that nice pink, healthy skin underneath. That's normal aging. So a lot of patients come to me and say, I have a fungal infection, and we've even done many, many tests, and they're all negative. And it's not fungus, it's just normal aging. Not to mention that there's a whole host of other skin conditions, from psoriasis to eczema to lichen planus, that all have similar and worse looking changes of the toenail that have absolutely not a single solitary thing to do with fungus. So before you start to invest in thousands of dollars of fungal treatment, make sure you get a good medical opinion to find out exactly what's happening. Not all yellow toenails are fungus. So again, here's the condition. This again is, there may be fungus in this toenail, but there's more going on here. This ram's horn shape of this toenail is actually a genetic condition. It can also be the result of years of what we call micro trauma, or scarring of the nail bed or skin underneath the nail. This person could take all the oral antifungal medications, both topical, they could take pills, they could have surgery, they could have laser, and the nails would grow back exactly the same. So we have to just keep that in mind. Again, my focus in my practice is primarily on palliative care. My patients don't want their toenails to become so long and thick that they're growing into the toe next to them, where it's becoming painful or interfering with shoe wear. We also don't want you to have a secondary infection like cellulitis that could potentially go into your bloodstream and put you in the hospital. So prevention of a lot of those foot pains, these are, my take home on shoes. I spend probably 90% of my day talking about shoes. So I'm amazed at how many people go through decades of their life and not have their foot size checked. Your foot constantly changes shape as you age. Does it grow? Not exactly growing. Your bones aren't growing, but your ligaments are loosening. I always joke and say, as we get older, everything kind of starts to sag and drop as we get older. Well, your feet are no exception. Remember from that earlier slide where I said you have over 100 muscles and ligaments supporting just the bones in your feet. Well, just like our jaws, our structure under our arms and everything else starts to sag with age, so do your feet. So that causes splaying and spreading, which means that your feet can change in width and length to some degree with age. Plus, we tend to lose the fat pads on the bottom of our feet. So we're all born just like little baby feet are just so soft and squishy, and we have all that nice fat pad cushioning. And as we age, we lose that. And I say lose it because, well, it doesn't disappear from our body. I think it just migrates to other areas we don't want or need it to be, where it should be under the balls of our feet or our heel bone, no more. But this means that as our skin thins as we age, we lose that fat padding. Shoes then are going to become more critical to help protecting those bones and joints in our feet so that we don't get painful corns and calluses. Weight changes. Your feet can get smaller. I've had patients who have had bariatric surgery or have lost tremendous amount of weight and their feet have gone down in size. Certainly width can change with swelling. So patients who may have different degrees of swelling, whether it's from heart disease or lymphedema, that certainly can affect shoe fit and can vary not only from day to day, but from morning to afternoon. So I always tell patients, if you are going out to have your shoe, to buy new shoes, and you're going to a reputable place, that you go preferably toward the end of the day when your feet are most likely to be at their maximum size of swelling. That way you're ensuring that the shoe fits you properly. We have to take into account, if you are wearing any type of prescription orthotic or insert, that we need to make sure that the shoe can accommodate that. And lastly, we need to make sure that the shoe is appropriate for the activity. So I have pictures of different shoes on this slide, and I despise every single one of these shoes on this slide. So when my patients come in wearing these shoes, I'm already cringing. These shoes are not functional for anybody. Let's start with the flats. Everybody knows that high heels are bad for you. But when I tell them that flats are probably worse structurally for your feet, not only your feet, but for your knees, your hips, your lumbar spine, your posture, your support, and can lead to a whole host of problems, they're shocked. Same thing, why walking barefooted in the house, wearing a flat is really no difference. It offers no structural stability or support. Slippers have been documented repeatedly as a trip and fall hazard. Repeatedly. If the shoe does not have any type of heel counter or a strap, just like these supposed sneakers, it has been statistically proven to be a trip and fall hazard. Again, doesn't provide any stability from the powerhouse, which is our ankle. So we tend to roll over them or out of them or off of them, not to mention that they get caught on steps and curbs and uneven surfaces. So I've had multiple patients who have sustained significant injuries as a result of wearing footwear that looks like this. The Keds, simply, yes, it's got a heel counter. Yes, it's a lace up. It's too flat and I can't put anything in it. There's just not enough room. They're too narrow in the toe and they're too flat. They might as well be in a ballet flat or a ballet slipper. So these are my least favorite types of shoes. Now, here's a picture of some of my favorite shoes. So if you come in wearing those other shoes, I'm going to make sure that the next time you come back, you're wearing one of these. These are the styles of shoes that I prefer my patients wear. This still is the gold standard of footwear if we're doing any type of exercise or walking activity. And don't underestimate the amount of walking it takes, for example, to do a run to Costco. That's a lot of walking on a hard floor. Probably best done in a sneaker. And we're looking specifically for lace up, heel counter, wide toe box. If you can take your shoe and bend it in half like a sandwich, it is not appropriate for walking. So we need to keep that in mind. The shoe has to have some type of structure, or stability. SAS is still the gold standard for extra depth footwear. So for my patients that have bunions and hammer toes, or like to wear orthotics or have inserts or splints that they need to wear, the SAS brand of shoes still tends to be the gold standard and is pretty readily available. This here is the type of slipper. This is a Bionic. This is the type of house shoe or slipper that I would prefer my patients wear as opposed to the open back or the slip-on. This has a nice firm heel counter. It's stable, rubber sole, and has the added ability of I could add an insert or orthotic if needed for that patient. Sandals, again, we're ideally looking for something that has some type of ankle or added strap of stability for that ankle joint. That's going to be what's going to roll you over. If you're in a shoe that doesn't have that, you're more likely to fall. All right, so orthotics, there are many different types of orthotics, from custom. The Power Step orthotic is my preferred brand of prefabricated orthotics. You know, you'll find a lot of things at the grocery store, Dr. Scholl's, Walmart, things in catalogs. Patients come in with a variety of different types of inserts. My advice generally is, unless you're being fitted specifically by a professional shoe fitter, an orthotist, or a physician, orthopedist, or podiatrist, it's probably not appropriate for you. I can't tell you how many patients come in to see me every day with bags. Literally, I had a patient a couple of weeks ago who came in with a suitcase filled with different types of orthotics devices that she had bought or had been fitted for her, custom things, and they were all either the wrong size, the wrong material. It was just a nightmare. So again, it's best to have a professional opinion before you just go out and buy, because there are so many different types. And it really depends on what your goals are, what shoe it's going into, and your foot type, obviously. A quick word about hygiene. I talk about this all the time with my patients, especially my diabetic patients or my immunocompromised patients. About, you know, everybody knows about washing and drying and trimming your nails straight across. Here's one that I do harp on a lot of my patients, especially my gardeners, and I'm an avid gardener, and I tend to garden in sandal type footwear, so my toenails are often dirty. Never, ever, ever stick anything underneath the edge of your toenail. I cringe when people tell me they go to a salon and the pedicurist goes with a cuticle stick and cleans out under the corners. I just start to cringe. Primarily, two reasons. One, your toenail is actually attached to your skin by a very, very, very thin membrane. If you break that membrane, the nail will very quickly detach from the nail bed. And two, should you have a fungal infection or any type of organism, whether it's a bacteria, fungus, mold, or yeast in the area, you could end up driving it further back under the nail where it's much harder to treat. So I keep a soft toothbrush, a baby toothbrush, in my shower, and with just some warm soapy water, just with the soft toothbrush, can use that to loosen any debris underneath my toenails. And that's really all you need to clean your toenails. Moisturizing, moisturize, moisturizer. Anybody out there that is a patient of mine knows. And if you come to my office and I've told you repeatedly to moisturize and you tell me I just didn't do it today, I can tell the difference. I know who's using moisturizer regularly and who isn't. And I have pictures of my two most recommended. CeraVe is probably one of my favorites. It's what I use personally, and I love the one in the jar. And I tell patients the best time to do it is actually at night before you go to bed. What's nice about CeraVe is it's not greasy, so you can put it on. I keep a jar of it literally on my nightstand by my bed. I rub it on my feet and toes every night, and I just go in under the sheets. I don't wear any socks. I don't need any kind of special wraps or anything like that. And it's not greasy. I could get up and walk across the bare floor and not slip and fall. So CeraVe is certainly at the top of my list. And the Gold Bond Ultimate Healing, it's a little bit thicker, but again, readily available. A lot of my male patients prefer the Gold Bond. They're both great products. Again, coupons available, Costco, Target, Walmart, Kroger, wherever you normally shop, should be easy to find. And these are my beautiful, my daughters. My oldest daughter is graduating from the University of North Carolina School of the Arts with her BFA in classical ballet. And everyone always asks me, how did two podiatrists raise a classical ballerina that dances on her toes all day? And I just answer, it was the ultimate teenage rebellion. She just wanted to do the one thing that was the antithesis of everything her parents stood for, but we're very proud of her. And she is moving on to a professional company as a trainee with American Repertory Ballet in Princeton, New Jersey. And my youngest is graduating from Albemarle High School, and she is my Broadway star, my future Broadway hopeful. And she just accepted a position at George Mason University, where she'll be studying musical theater in the Honors College there. So I'm very proud of my girls. And if you come to my office, you'll see pictures of them everywhere. So Carolyn, I think we can open it up to questions. What have you got for me?
Sure. Yeah. Well, one question is, are pedicures counter recommended for toenail fungus?
So that depends. That's a little complicated. So typically, I must admit that the salons in our area in Charlottesville are very engaged, meaning if they see a patient with toenail fungus that they're concerned about treating, they're very quick to refer to a podiatrist. I certainly wouldn't buy anything from a salon to treat my toenail fungus unless you've had a professional opinion, because again, there are so many things that look like fungus that aren't really fungus that you could just be wasting your time and money. I'm more concerned about my immunocompromised patients, my diabetics, my cancer patients, my rheumatoid arthritis patients, having a salon pedicure than I am about toenail fungus patients. If you're asking, can you contract an infection from a salon? Absolutely. I see it all the time. My advice, if you are one to have a salon pedicure, bring your own tools. It's allowed. And if you go to a salon and they don't let you bring your own tools, then find another salon. But that's a very quick, hygienic way. They do uphold all the sanitation protocols that OSHA expects. So as far as basins and things like that, it should be clean. But bring your own nail clippers and tools, and that should solve that problem.
Great. Thank you. Shobha says, very informative talk. Thank you. A couple of questions. Should we moisturize the bottom of the feet?
Yes, so you should moisturize everywhere where there's skin. So that's everywhere. So yes, bottom, top, and everyone asks, I've always been told never put cream between my toes. That's kind of an old wives' tale, to be honest with you. With the newer creams and lotions that are on the market now, like CeraVe, like Gold Bond, those things are so highly engineered and specific that they're actually very, very safe to use between the toes. So yes, absolutely. I tell my diabetics all the time, make sure that you're rubbing some lotion and cream, because you don't want that skin to get dried out and cracked and painful in between the toes. So yes, if you're using something even like Aveeno or Jergens, those products are all fine. I would probably stay away from like the Vaseline petroleum jelly or the things that you get at like Bath and Body Works, which by the way are not moisturizer lotions. Those kinds of things, probably not good for in between the toes, but yes, bottoms of the feet, sides of the feet, tops, in between the toes and around the toenails. And don't forget the tips of the toes. I have many patients who come in with dry, cracked skin around the tips of the toenails. It makes it dangerous if you're trying to clip your own toenails and the skin's all dried and cracked, that if you cut yourself, you'd be more likely to get a bacterial infection. So make sure you're keeping all that skin soft.
Great. I've never thought so much about my feet. This is really,
That's
of
my
course, that's your
job.
job, right? What about going barefoot? Is it okay? We have several other questions.
Yes, another loaded question. So much research has gone into barefoot activities, and my general, after reviewing and being at all the conferences and seminars and on both sides of the aisle, my general consensus is this: there is certainly benefit to going barefooted if the barefoot activity is intentional. And what I mean by that is if you're doing a specific exercise like ballet or bar or yoga or Nia, if you're doing, or Pilates, or Goscue, if you're doing a specific activity in which you are focused on position, ankle, joint, posture, muscle, flexibility, then absolutely going barefooted can help strengthen those muscles in our feet. The problem we get into is when we're running around barefooted outside of those activities, walking around the house barefooted, and we're getting up to go to the refrigerator, or to the bathroom, or the doorbell rang, or we got to go pick up the phone, and you're not paying attention to your muscles, your joint, your posture, or your alignment, you're potentially setting yourself up for injury. And I see a lot of problems come from that. Not to mention that corns and calluses, especially in my patients who have lost a lot of the fat padding, that's going to accelerate the development of those corns and calluses if you don't have a lot of cushioning on the bottoms of your feet. So for specific exercises, yeah, it's okay to go barefooted. All the rest of the time, no.
Okay. Wow, 10 more questions here. Nails on 2 small toes have the sides growing towards each other. What is the cause? What can be done? For example,
Genetic. Most often it's genetic, and we refer to that as a pincer nail. The 2 sides can actually grow together and form a circle, and that's genetic. So the best treatment options are to keep the nails and skin soft, and to keep the nails trimmed and filed shorter or thinner than you think you should. Not to the point where it's bleeding, because you have to be careful of that skin underneath, but the nails should be trimmed and filed shorter, and that's a lot easier to do if the skin and nails are softened with moisturizer.
great. Plantar fasciitis remedies?
Yeah.
Question mark,
So no
exclamation.
barefoot walking, that's number one, and it's all about the shoe. It really is about the shoe. So if you're in a shoe that's flat, like those Keds, or the open heel shoes and slippers and things like that, absolutely going to cause a problem. Flats for sure will exacerbate plantar fasciitis. It's got to be a stable shoe that you can't bend in half, and that has some type of heel stability or ankle stability. So again, my patients, if you come to me with heel pain, if you're not already wearing a running sneaker, I will make you go out and buy one before we do anything else.
Great. This is someone else, but I'm using I have loose toenails on my big toes. Is it okay to paint my toenails?
I'm sorry, I missed the first part of that.
Sure. They have loose toenails on their big toes. Is it okay to paint those toenails?
So painting, painting has never been proven to cause or exacerbate toenail fungus. Absolutely, you can paint them. I always caution my patients, if the problem with painting and polishing, of course, is if there's bleeding underneath the nail, or bruising or darkening, because if the nails are loose, and say you go hiking and your nails are polished, you may not realize that you've developed a bruise or some bleeding underneath that nail. And a lot of times I have patients who take their toenail polish off after, say, the summer, and they come in a panic and say, oh my God, my whole toenail is black. I had no idea. And when we question them, we find out, they were on vacation, at the Grand Canyon months ago, and they probably sustained. So toenail polish is fine, but I don't like patients keeping it on for months at a time. I think it's important to continually monitor the health of your skin and nails.
Great. Could you also name the best orthotic you mentioned, the one that you can get at the store or whatever?
The Power Step. So the Power Step is hands down probably the most functional insert. The only places locally that I know where you can get that, Ragged Mountain Running Shop, and most podiatrist offices do carry the Power Step. Amazon carries several models of the Power Step. There are different types. Again, when it comes to orthotic therapy, there's probably a good dozen or more different types of Power Step. So I've had patients come in and they've ordered the wrong one off of Amazon. And to further complicate things, Orthotics or arch supports should match your arch length, not your shoe size. So a lot of times I have patients who come in who say, well, I've always worn a size 8. I bought a size 8 orthotic, and the orthotic's actually too short. And I end up putting them in a 9 that we cut down to fit the shoe, and it takes care of all the problems.
Interesting. Huh. I agree with this. Wonderful information-filled talk delivered enthusiastically.
Thank you.
Next question. Can you address fallen arches and ankle pain?
Yeah, again, a lot of times with falling arches and ankle pain specifically, it's shoes that are going to exacerbate the pain and inflammation. The fallen arch is fallen. Once it falls, it falls. So unless you're having surgery to reconstruct it, it's structurally you are what the flat structure is what you're stuck with. But whether or not it hurts, I mean, I have children who were born with no arch, completely flat feet, and they have no pain, and they can run and athletically participate in sports because they're wearing a shoe that's appropriate for them. So the problem with pain is that it's when there's inflammation of the structures around the foot and ankle. So as long as you're supporting that foot with good shoes, stability, not running around barefooted, then you shouldn't have pain.
Great. Let's see. When can a fungus on a toenail spread infection to the rest of the feet, and how would you know?
So it's both the nail and the skin are the same same class of organism. So it's a dermatophyte. So contrary to some patients' belief, it cannot get into your bloodstream. There are fungal infections that cause lung infections and different types of systemic infection, but the ones on your toenails are not that organism. Even if you cut yourself with a fungal toenail, you're not going to get a deeper infection. It cannot infect anything. But absolutely, a toenail fungus can infect your skin on your feet. And for some of my male patients out there, it can also cause conditions like jock itch. So if you're drying your feet when you get out of the shower, we always tell our patients to make sure that if you have fungus, that you're using a separate towel for your feet, not using that towel to dry the feet and then bringing it up the leg to the groin area, because that can cause a problem. It's the same organism. So yes, it's contagious and can spread to any skin structure. For women, we can see it under the breasts or in the armpit as well. So either separate towels, or as my dermatologist mentor used to say, we dry from the top down.
That's great advice. Congratulations to your daughters. I dance too, and I need to wear tennis shoes. Wonder if I need new orthotics.
Well, I don't know, but if you've worn, if you've worn orthotics in the past, for many patients, yes, it's probably necessary. What I find though is that a lot of my patients who have worn custom orthotics for decades don't need the rigid control of the custom orthotic and can get away with something prefabricated like a power step. And because shoes nowadays are so highly engineered that oftentimes I can recommend a specific shoe and an insert if necessary. But for some patients, we get to a stage in our life that we just don't even need all that control.
Great. Another question is a spot that feels like a small rock on the ball of the foot between the big toe and the second toe, just a callus.
So it depends. Yes, if it's on the skin and you see sort of that thickened yellow tissue, then yes, that's probably a callus. But you also have two little round bones inside your foot at that area. So if you look at your skin and your skin is normal and there's nothing on the skin, then it's possible you could be feeling one of those little round bones. It's called the sesamoid.
Okay. If someone at the gym has toenail fungus, can we catch that fungus?
Yep, sure can. And everybody knows, all my patients come in and say, when I go to the gym, I always wear flip-flops in the shower and I never go barefooted in the locker room. And I know that. And yes, pools, public areas, gyms are very common places for picking up fungus. but there are some that a lot of people don't consider. One, yoga studios. So if you're using somebody else's yoga mat, you could get that. And two, the most common place where we believe toenail fungus is contracted, hotel carpeting.
Mm.
If you're walking around a hotel room barefooted, that seems to be the place.
That's lovely.
You're right. Make you think about that next time. When we all get to travel again, think about that when you're in the hotel room.
I have constant pain in my bone on the left foot by the arch. Recommendations?
Well, there are a lot of bones in that part of the foot, so it'd be hard to say. Again, always with every patient who comes to me with any of the itises, my first thing I'm going to ask is, have you been wearing sneakers? If you're wearing a running sneaker and it still hurts, then you need to see a doctor.
Good advice. I'm sorry, I'm not sure if you answered this already, so I'll repeat it. Does our arch get flatter as we age?
Yes, yes. How much it does is genetically determined, but again, once that ligament structures, and for women in particular, it can be more dramatic because it's hormonally dictated. So as we get post-menopausal, everything starts heading south, and that includes the ligaments that support our arches. So yes, our feet do get flatter as we get older.
Several, thank you so much. Very informative. Thanks for answering all the many questions. Another question, how does one prevent Achilles tear or partial tear?
So stop sprinting in sudden jumps and movements. Most Achilles tendon tears or ruptures are due as a result of a sudden forceful movement. So they tend to be prevalent in our basketball players that are leaping and jumping, our sprinters that are taking off from a sudden stop. Those are the conditions that tend to cause tearing. Now you can have tendonitis or an inflammation around the tendon in which the tendon structure is intact, but you have swelling or inflammation around the tendon. That's a little bit more complicated. But as far as tears go, it's all about that sudden. We used to call them, when I was in medical school, we used to call them weekend warriors, the people who would sit at a desk all day, Monday through Friday, and then go out on Saturday and Sunday and play basketball. And then sure enough, Achilles tendon tears would occur. Also caution, if you started doing any kind of stretching exercises, I do not like the stretches where you drop your heel down on a step. I have seen a few Achilles tendon tears occur because somebody's foot slipped too far down. And again, sudden motion can cause that.
Viv says, great talk by a great podiatrist. Thanks so much. And I would like to thank, we can still go on, we have a few more minutes, but I neglected to thank Berta Heisel, our center member, who asked Dr. Heather to give this talk. And obviously, by all of the questions and comments, it's been a great talk. So I've also allowed folks to unmute themselves. So if you care to ask a question using your voice, please feel free to do that. So Gigi and Mary Lou just unmuted. Gigi, did you want to share?
Yes, Heather, you're my doctor.
I remember you, Miss Payne.
Yes,
How are
I have
you?
to come back. I have been dancing like crazy during this COVID stuff, and the tops of my feet hurt of all things.
Yeah.
And all kinds of things are going on. And of course, I hit 70.
Congratulations.
Yeah, really. And everything you said just put it all in a big picture for me. And I said, appointment time is necessary.
That sounds good. Thank you, Miss Payne.
And I'm so excited about your daughters. My granddaughter is a ballet dancer and she is so marvelous. It's so fun.
Great. I love it.
Thank you.
Thank you.
Thank you. Mary Lou, did you want to say something?
Well, actually, it's a personal thing, and I think I just need to see. I need to see a podiatrist. I mean, you can look at my foot now, but it's not fair to the other. Yeah, I'm just having a problem with the big toe, and it's swelling, and I just, and the bone, there's a bone coming up. So I don't know. I don't think it's a bunion, but I need an exam. So
Yeah,
one more thing.
it sounds like it, again, there's so many possible things that can go wrong.
Yeah, there's like you said, there's so many bones in there that
There are, even in your big toe, just in the toe itself, you have two. And some people are born with extras.
Oh my heavens.
This to make my job even more fun.
special.
Barbara Rogers, did you want to?
Thank you.
Yes. What is the difference between a podiatrist and an orthopedic doctor?
Good question. Good question. And I get that a lot, especially in my patients who are considering surgery. Do I go to a podiatrist or do I go to an orthopedist? So here's how this works. Both podiatrists and orthopedists start medical school together. First 2 years, we're in the same classes. We do all the gross anatomy. Yes, I did the cadaver studies just like they do. The microbiology, the physiology, the anatomy, all of that is all the same. In podiatry school, in the 3rd year, we then shift to below the waist only. So my MD colleagues go off and they may do rotations even in psychiatry, OBGYN. Us in podiatry, we stick with things like infectious disease, rheumatology. We don't do cardiology either. So cardiology and gastroenterology, the MDs would take that over. But so we focus mostly on the lower extremity. So after podiatry school, we then do a residency program, just like our MD. So we meet back with our MD colleagues. And our first year of residency can often overlap with our MD because that's sort of your general rotations. And then after that is when we start to specialize. And again, podiatrists primarily looking mostly at musculoskeletal and lower extremity, whereas my MD colleagues are looking at everything. But yes, I mean, we do rotations in dermatology. So I have seen my fair share of genital lesions in rotation and all of that. But my MD friends end up staying in that sort of realm, and podiatrists focus more on the feet. So when it comes to patients requiring surgery, they often ask, which one would you go to? And I always answer very honestly, it's whatever surgeon I'm most comfortable with. You need to be comfortable and trust your surgeon. So, and do what they say. So whoever, whether it's a DPM or an MD, I feel like we're both adequately trained.
We have one last question. I think we have time real quick. One of my pincer toes is dark. Should I be concerned?
So again, dark can be an indication that there's bleeding underneath the nail at some point, not necessarily actively. It can be something that happened months ago. And then a patient looks down or takes off the polish and goes, hey, when that happened? Oftentimes that discoloration will grow out. The only time we worry about dark discoloration under a toenail is one, if it's painful or there's active drainage and the nail's starting to lift up and there's blood oozing out from underneath, that would be a problem. Or if the black discoloration is spreading down the skin onto the toe itself, that unfortunately could be an indication of melanoma. But keep in mind that melanomas in the feet are extremely rare and almost unheard of. So less likely.
Great, great. Well, thank you so much for a very surprisingly upbeat talk about feet.
I love feet. What's not to be upbeat?
Yeah, well, you did call it making your feet happy. So we appreciate your time and coming back to us with improved internet. Thank you so much, Dr. Heather.
Thank you, Carolyn.
And thank you all for coming.
Thank you, everybody. Go take care of your feet and go get your sneakers.